specificity is known as adaptive immunity, and they can have a more specific response compared to acute inflammation. And that is how you know chronic inflammation can be involved. The stimuli for chronic inflammation includes number 1, persistent infection. That happens to be the most common cause. Number 2, infection with viruses, mycobacteria, parasites, and fungi. Number 3, autoimmune diseases. Number 4, foreign materials. And number 5, some cancers. So again, they are persistent infection. That happens to be the most common cause. Infection with viruses, mycobacteria, parasites, and fungi. Autoimmune diseases, foreign material, and then some cancers. Let's talk about T lymphocytes. So T lymphocytes are produced in the bone marrow as progenitor T cells. However, they further develop in the thymus, where the T cell receptor, or the TCR, undergoes rearrangement, and the progenitor cells become the CD4 plus helper T cells, or the CD8 plus cytotoxic T cells. And the T cells use the T cell receptor complex, like the TCR and the CD3, and still use the T cell receptor complex for antigen surveillance. So, the T cell receptor complex recognizes antigen presented on the MHC molecules. MHC stands for Major Histocompatibility Complex. So the CD4 plus T cells will bind to the MHC class 2 molecules, and the CD8 plus T cells will bind to or attach to the MHC class 1 molecules. So you can think about the rule of 8s where 8 times 1 equals 8, while 4 times 2 equals 8, to know which MHC class molecules the CD4 or the CD8 binds to. And then the activation of T cells requires the binding of the antigen and the MHC complex, and then an additional second signal. Again, the antigen has to bind to the MHC complex, whereby the MHC complex presents the antigen to the T cells, and then there also has to be an additional second signal. Let's talk about CD4 plus helper T cell activation. So, in this case, the extracellular antigen, like a foreign protein, is phagocytosed, processed, and presented on the MHC class 2 molecule, which is expressed by the antigen presenting cells, or the APCs. Again, it's the extracellular antigen that is involved, presented on MHC class 2, and this MHC class 2 happens to be expressed by the antigen presenting cells, also known as APCs. And so, speaking of the antigen presenting cells, the B7 on the antigen presenting cells will bind to the CD28 on the CD4 plus helper T cells, and this will provide the second activation signal that is required. And then the activated CD4 plus helper T cells will secrete cytokines that quote unquote help the inflammation, and are divided into 2 subsets. So the cytokines or the T cells that are divided into 2 subsets are the Th1 and the Th2 subsets. So the Th1 subset secretes interferon gamma, or IFN gamma, and this will activate the macrophage, specifically the interferon gamma. So activate the macrophage, promote B cell class switching, B-cell class switching from IgM to IgG, and also promote Th1 phenotype and inhibit Th2 phenotype by the secretion of the interferon gamma. Now, the Th2 subset will secrete the interleukin-4 or the IL-4, and the interleukin-4 will facilitate the B-cell class switching to the immunoglobulin E or IgE. The Th2 subset also secretes interleukin-5, and this interleukin-5 will facilitate eosinophil chemotaxis and activation, and also the class switching to immunoglobulin A or IgA. Again, interleukin-5 has the, or you can think about the fifth letter in the alphabet is the letter E. Remember that interleukin-5 involves eosinophil chemotaxis and activation. And then, of course, it is also involved in class switching to IgA. And finally, the Th2 subset will also secrete interleukin-13, which carries similar function to interleukin-4. So in summary, Th2 secretes interleukin-4, interleukin-5, and interleukin-13, while the Th1 subset secretes interferon gamma. And then we also have the CD8 plus cytotoxic T cell activation. So this time we have intracellular antigen, which is derived from proteins in the cytoplasm. And so the intracellular antigen is processed and presented on the MHC class 1 molecule, which is expressed by all nucleated cells and platelets. So remember, MHC class 1 is expressed by all nucleated cells and platelets, while MHC class 2 is expressed by antigen-presenting cells. Anyways, the interleukin-2 that is from the CD4 plus Th1 cell will provide the second activation signal. Again, that's interleukin-2 from the CD4 plus Th1 cell that will provide the second activation signal. In order for the CD8 plus cytotoxic T cell to be activated. And that is why the CD4 plus T cell is known as helper T cell. So the cytotoxic T cells are activated for the purpose of killing. And the way killing occurs through cytotoxic T cells is through the secretion of perforin and granzymes. So perforin will create pores that allows granzyme to enter the target cell, thus activating apoptosis. And there's also going to be expression of FASL or FASL, which binds to the FAS on the target cells, and this will also trigger or activate apoptosis. Now let's talk about B lymphocytes. Yes, so B lymphocytes are involved with the development of B cells. So immature B cells are produced in the bone marrow, and they will undergo immunoglobulin rearrangements to become naive B cells that express the surface IgM and IgD. So B cell activation occurs through the following processes. So the antigen binding by the surface immunoglobulin M or the immunoglobulin D. This will result in the maturation to immunoglobulin M or immunoglobulin D, secreting plasma cells. Again, that's antigen binds to surface or antigen binding by surface IgM or IgD. And this will trigger maturation of these immature IgM or IgD into a more mature form. the second activation signal. The helper T cells will then secrete interleukin 4 and interleukin 5. And remember, this will mediate the B cell isotype switching, along with hypermutation and maturation to plasma cells. So again, the way B cells are activated is through antigen binding by surface IgM or IgD, which then results in maturation to IgM or IgD secreting plasma cells, and then also the B cell antigen presentation to CD4 plus helper T cells, where once it is presented to this cell, the CD40 receptor on the B cell will bind to the CD40L on the helper T cell, providing the second activation signal. And the helper T cells will then secrete interleukin 4 and interleukin 5, which will mediate B cell isotype switching, hypermutation, and maturation to plasma cells. Now let's talk about granulomatous inflammation. Granulomatous inflammation is a subtype of chronic inflammation. It is characterized by the formation of granuloma, which is a collection of epithelioid histiocytes, which are macrophages with abundant pink cytoplasm, and they're usually surrounded by giant cells and a rim of lymphocytes. So remember, it's a collection of epithelioid histiocytes, usually surrounded by giant cells and a rim of lymphocytes. They involve macrophages with abundant pink cytoplasm. Granulomatous inflammation can be divided into non-caseating and caseating subtypes. So the non-caseating granulomas lack the central necrosis. And common etiologies of non-caseating granulomas include reaction to foreign materials, sarcoidosis, beryllium exposure, Crohn's disease, and a cat scratch disease. On the other hand, caseating granulomas exhibit central necrosis and are characteristic of tuberculosis and fungal infections. Now let's talk about the steps involved in granuloma formation. Okay, so the steps for granuloma formation include the following. So the macrophages are processed or they process and present antigen through the MHC class II molecules to the CD4 plus helper T cells. And then this interaction leads the macrophages to secrete interleukin 12. And this interleukin 12 will induce CD4 plus helper T cells to differentiate into the Th1 subtype. So remember that the Th1 cells will secrete the interferon gamma, which will then convert macrophages to epithelioid histiocytes and giant cells. Again, remember that this interaction of macrophages to CD4 plus helper T cells will involve the secretion of interleukin 12, and this will induce CD4 plus helper T cells to differentiate into Th1 subtype. And Th1 cells will secrete interferon gamma, and this will convert macrophages to epithelioid histiocytes and giant cells. Now let's talk about primary immunodeficiency. So first we have the George syndrome. The George syndrome involves the developmental failure of the third and fourth pharyngeal pouches. And so this is due to the chromosome 22 long arm 11 microdeletion or 22q11 microdeletion. And this will present with T cell deficiency immunodeficiency, or SCID. This involves defective cell-mediated and humoral immunity. Etiologies include the following. First, we have the cytokine receptor defects, and this is because cytokine signaling is necessary for the proliferation and maturation of B and T cells. So obviously, cytokine receptor defects will lead to immunodeficiency. We also have adenosine deaminase deficiency, or ADA deficiency. The adenosine deaminase is necessary to deaminate the adenosine and deoxyadenosine for excretion as waste products. On the other hand, buildup of adenosine and deoxyadenosine is toxic to lymphocytes. So adenosine deaminase deficiency can ultimately lead to toxicity and destruction of lymphocytes due to the buildup of adenosine and deoxyadenosine. Then we have MHC class II deficiency. Remember, MHC class II is necessary for CD4 plus helper T cell to become activated. They're also necessary for cytokine production. So obviously MHC class II deficiency is another important etiology of SCID. So severe combined immunodeficiency is characterized by the susceptibility to fungal, viral, bacterial, and protozoal infections, including opportunistic infections and live vaccines. And then treatment is sterile isolation and stem cell transplantation. You can think about the bubble baby to reverse sterile isolation. Now let's talk about the X-linked A-gamma globulinemia. So X-linked A-gamma-globulinemia involves a complete lack of immunoglobulin due to the disordered B-cell maturation. So the pre and the pro B-cells cannot mature. This is due to the mutated Bruton tyrosine kinase, and this is inherited through X-linked pattern. So mutated Bruton tyrosine kinase, X-linked inheritance pattern, involves a gamma globulinemia. The X-linked A-gamma globulinemia is present after 6 months of life when recurrent bacterial enterovirus, such as polio and Coxsackie virus, and Giardia lamblia infections, and the maternal antibodies that are present during the first 6 months of life are protective. So, when someone has X-linked A-gamma globulinemia, live vaccines like the polio vaccine must be avoided. Alright, so here's some histological images of a granuloma. So at this figure, this is an example of a non-caseating granuloma without central necrosis. And here is a caseating granuloma with central necrosis. And then here is an example of an this is due to the mutated CD40L that is on the helper T cells, or the CD40 receptor that is found on the B cells. So when this happens, the second signal cannot be delivered to the helper T cells during the B cell activation, and consequently, the cytokines that are necessary for immunoglobulin class switching are not produced. Because remember that we talked about earlier how the CD40 receptors on the B cell bind to the CD40L on the helper T cells, providing the second activation signal. And helper T cells will then secrete the interleukin-4 and interleukin-5 to mediate B cell isotype switching, hypermutation, and maturation to plasma cells. And then don't forget also that Th1 subset of CD4 plus helper T cells will secrete interferon gamma, where one of its functions is to promote B cell class switching from IgM to IgG while activating macrophages. So anyways, that's the pathophysiology behind the hyper-IgM syndrome. And then, because of this, the low IgA, or immunoglobulin A, immunoglobulin G, and immunoglobulin E will result in the recurrent pyogenic infections. And this is due to the poor oxidization. And these recurrent infections will occur especially at the mucosal sites. So the low IgA, IgG, and IgE result from the inability to class switch the immunoglobulin, thereby resulting in more IgM production. Then we have Wiskott-Aldrich syndrome. So Wiskott-Aldrich syndrome is characterized by thrombocytopenia, eczema, and recurrent infections due to the defective humoral and cellular immunity. And unfortunately, bleeding in this case is a major cause of death. So the Wiskott-Aldrich syndrome is due to the mutation in the WASP gene, or the WASP gene. And then it involves an X-linked inheritance pattern. So you can think about WASP acronym, where W stands for Wiskott, A stands for Aldrich, S stands for syndrome, and P stands for penia and thrombocytopenia. And then we have complement deficiencies. So this is very important to know. So in complement deficiencies, they mostly involve the C5 through the C9 complement protein deficiencies. This can lead to increased risk for Neisseria infections. So from the Neisseria gonorrhoeae and Neisseria meningitis infections. And then the C1 inhibitor deficiency can result in hereditary angioedema, which is characterized by the edema or the swelling of the skin. And this can especially occur in the periorbital area and on mucosal surfaces. So angioedema on the skin and mucosal surfaces and periorbital area that we saw earlier. And the hereditary angioedema is caused by the C1 inhibitor deficiency. The central tolerance in the thymus leads to the T cell or thymocyte apoptosis, or the generation of regulatory T cells. So, the AIRE or the AR mutations will result in autoimmune polyendocrine syndrome. Again, AR mutations result in the autoimmune polyendocrine syndrome. The central tolerance in the bone marrow leads to the receptor editing or even B cell apoptosis. On the other hand, the peripheral tolerance leads to the anergy or the apoptosis of both the T and B cells. So the way this works is that the FAS or FAS apoptosis pathway mutations, if it is mutated, it can result in autoimmune lymphoproliferative syndrome. And this is because the FAS apoptosis pathway is critical for this peripheral tolerance mechanism. And so if the FAS apoptosis pathway mutations are involved, or the pathway is mutated, this can lead to autoimmune lymphoproliferative syndrome, or ALPS, or ALPS. And then regulatory T cells will suppress autoimmunity by blocking the T cell activation, and they will also produce anti-inflammatory cytokines, which again are the interleukin 10 and TGF-beta. So, interestingly, the CD25 polymorphisms are associated with autoimmunity, such as in multiple sclerosis and type 1 diabetes mellitus. And in the FOXP3 mutations lead to the IPEX syndrome, or the IPEX syndrome. IPEX is an acronym for immune dysregulation, polyendocrinopathy, enteropathy, and X-linked inheritance pattern. And SIPEX, immune dysregulation, polyendocrinopathy, enteropathy, or enteropathy, and X-linked inheritance pattern. That's IPEX syndrome, and it is due to a FOXP3 mutation. So autoimmune disorders happen to be more common in women, and they classically affect women of the childbearing age. And then this is because estrogen may reduce apoptosis of the self-reactive B cells. And then the etiology of autoimmune disorders can also be likely due to environmental trigger in genetically susceptible individuals. So there can be increased incidence in twins with such conditions. Regarding etiologies from environmental triggers, it can be associated with certain HLA or human leukocyte antigen types, like the HLA-B27 and BTPN22 polymorphisms. And then environmental triggers can lead to bystander activation or molecular mimicry. And then autoimmune disorders are clinically progressive with relapses and remissions, and often show overlapping features. They can be partially explained by epitope spread happens is that the poorly cleared apoptotic debris, such as from the ultraviolet damage, will activate the self-reactive lymphocytes, which will then produce antibodies to the host nuclear antigens. Then the antigen-antibody complexes are generated at low levels and taken up by the dendritic cells. Afterwards, the DNA antigens will activate the toll-like receptors, thus amplifying the immune response, probably through the interferon alpha cytokine. And then, after the DNA antigens activate the toll-like receptors and ultimately amplify immune response, the antigen-antibody complexes are subsequently generated at higher levels and ultimately deposit in multiple tissues, causing the disease. And then the deficiency of early complement proteins like the C1q, C4, and the C2 complement proteins is associated with the systemic lupus erythematosus. So in systemic lupus erythematosus, almost any tissue can be involved. Some classic findings include fever, weight loss, fatigue, lymphadenopathy, and Raynaud phenomenon. Again, that's fever, weight loss, fatigue, lymphadenopathy, and Raynaud phenomenon. Patients can also present with malar butterfly rash, as shown over here. So here's a malar butterfly rash, and they can also present with discoid rash, as shown over here. There's a discoid rash, and this can happen especially upon the exposure to sunlight. There can also be oral or nasopharyngeal ulcers, but they're usually painless. And then they can have arthritis that usually involves greater than or equal to 2 joints. They can also have serositis, like pleuritis and pericarditis. They can have psychosis or seizure episodes. They can have renal damage. So renal damage involves diffuse proliferative glomerulonephritis, is the most common and most severe form of injury. And other patterns of injury, such as membritis, glomerulonephritis, can also occur. They can also have anemia, thrombocytopenia, or leukopenia due to the type 2 hypersensitivity reaction. They can have Lippmann-Sachs endocarditis. Yeah, I think that's pronounced Lippmann-Sachs endocarditis. And then anti-nuclear antibody. So the anti-nuclear antibody test, or the ANA, it is sensitive but not specific for systemic lupus erythematosus. On the other hand, the anti-double-strand DNA, or the anti-smooth muscle antibodies, also known as anti-SM antibodies, are highly specific. And then the antiphospholipid antibody is associated with the systemic lupus erythematosus in 1/3 of patients. So for antiphospholipid antibodies, they involve autoantibodies that are directed against the proteins that are bound to the phospholipids. Okay. And then continuing on regarding antiphospholipid antibodies. So the important syndrome is characterized by the hypercoagulable state due to the antiphospholipid antibodies, especially the lupus anticoagulant. And then this will result in the arterial and venous thrombosis, including the deep venous area, the hepatic vein, the placental anti-SSA/RO and anti-SSB/LA. These are the anti-ribonucleoprotein antibodies. The anti-SSA and the anti-SSB are associated with the extraglandular manifestations like neuropathy. And then pregnant women with anti-SSA antibodies are at risk for delivering babies with neonatal lupus and congenital heart block. And the anti-SSA and anti-SSB are also seen in a subset of patients with the systemic lupus erythematosus. And that is why you have to screen pregnant patients for these antibodies. And then the Sjogren's syndrome can also involve lymphocytic cyanidinitis on the lip biopsy. And this can serve as an additional diagnostic criterion. So the lymphocytic cyanidinitis on lip biopsy can be found in minor salivary glands. And then in Sjogren's syndrome, there's increased risk for B-cell, specifically marginal zone lymphoma, which presents as